Hey, welcome back everybody. I'm Dr. Shahid, and in this video, we're going to go through the high-yield information surrounding plaque and biofilm. Okay, here we have some visible dental biofilm on the surfaces of these teeth. Biofilm can also be called plaque, and it's a group of bacteria that sticks on tooth surfaces. It includes not only the bacteria, but their byproducts and a sticky matrix called an EPS. EPS stands for extracellular polymeric substance. So the EPS is what gives the biofilm structure and protects the bacteria. Now, a key bacteria you should definitely know as a hygienist and for the exam is Streptococcus mutans, and it's strongly linked to dental caries. This bacteria makes an enzyme called glucosyltransferase. This is an enzyme that turns sucrose into dextrin, and dextrin is part of that sticky polymer I was just talking about that helps the bacteria stick to the tooth and group together. Of course, Strep mutans isn't the only bacterial species in biofilm. We also have Lactobacillus species and Actinomyces species as well. In fact, each biofilm contains hundreds of unique species, and we'll learn about some throughout this video. Alright, let's zoom into this bacterial matrix. Bacteria found in biofilm are much harder to kill than bacteria that live on their own, and that's because biofilm gives them a stable environment and makes them more resistant to threats like antibiotics. So I want you guys to know 4 specific ways that biofilms help bacteria. The first is by supporting a broad habitat. So biofilms support many types of bacteria, both aerobic and anaerobic, depending on where it forms in the mouth. The second thing I want you to remember is metabolic diversity. Biofilms are metabolically active and very efficient. Bacteria and biofilms share nutrients with each other. One species can have a byproduct that they don't need, and guess what? That's another substrate for a different species. So it creates this symbiotic food chain and improves efficiency since there's no wasted nutrients. Pretty cool stuff. And here's one twist students often miss. Even though biofilms are metabolically diverse, many of the bacteria deeper inside the biofilm actually shift into a low metabolism, slow growing state, and this makes them much harder to kill with antibiotics, which brings us to our third point, which is that biofilms are resistant. Bacteria can share resistance genes, and as a refresher, this is called horizontal gene transfer. So this includes genes for enzymes like beta-lactamase. So in essence, biofilms can block the action of antibiotics. Biofilms also protect themselves by eliminating competing organisms. They release acids, toxins, and bacteriocins that suppress or kill species that threaten the biofilm stability. So only the bacteria that support the community will survive. The last thing I want you to know is that there's increased pathogenicity with biofilms. Biofilms lead to chronic infections like periodontitis and cavities. That's because they boost the production of harmful toxins, acids, and proteases that can damage the surrounding tissues. Needless to say, guys, biofilm is not our friend. They're actually the main cause of periodontal disease and how our immune system reacts to that. But biofilms are found in both healthy and diseased mouths. The difference is the type of bacteria that they contain. So healthy gums have healthy bacteria, and as such, they show clinical health. In gingivitis, the gums are inflamed, but there's no permanent damage to bone or the periodontal ligament. You'll get a slight increase in probing depths simply because the gingiva is inflamed, but there isn't any bone loss just yet. Periodontitis is more severe. It involves permanent destruction of the periodontal ligament, alveolar bone, and surrounding tissue. So as you would expect, probing depths are significantly higher. Alright, now we're going to go through each of these states, and I'm going to mention some high yield points that you should remember for your exam. We'll start off with the healthy state. Here, the sulcus mainly contains aerobic gram-positive bacteria. They're part of the normal microbiome, and they help keep the gums healthy. Easy peasy. Now let's zoom in to the gingivitis state. So as plaque builds up, the oxygen levels drop in the gingival sulcus. This in turn creates an anaerobic environment, so it makes sense that bacteria well suited to these environments begin to dominate. And that's exactly what happens. Gingivitis is marked by a shift from aerobic gram-positive bacteria to anaerobic gram-negative bacteria. Gingivitis is also marked by the presence of PMNs, or polymorphonuclear leukocytes if you want to be fancy. These are the first immune cells to respond during the inflammatory phase. Another high-yield condition surrounding gingivitis that I want you guys to know is necrotizing ulcerative gingivitis, sometimes called NUG. You may be more familiar with ANUG, which is the acute version of this disease, but the two are essentially the same thing in their clinical signs. They're both infections with punched out papillae, gingival bleeding, and of course pain. It also has a nasty odor, so hopefully you guys don't encounter this too often. But what's important here are the bacteria. NUG is mostly associated with Fusobacterium, P. intermedia, and T. denticola. However, P. gingivalis and T. forsythia, which are usually associated with chronic periodontitis, can also be present here, although to a lesser degree. Alright, lastly, let's take a closer look at periodontitis. So first things first, what type of bacteria would you think dominates the gingival sulcus in periodontitis? If you guessed anaerobic gram-negative, you'd be right. And that should make intuitive sense because those are the same guys that were starting to dominate in gingivitis. So as the disease progresses, you would expect an even higher proportion of them in the sulcus. Now, as you guys know, the thing that transitions gingivitis to periodontitis has nothing to do with plaque or biofilm. It's actually the host immune response. You see, the bacterial gunk in plaque tells the body that there's something on the tooth that shouldn't be there, so the body wants to fight it. And that's usually a good thing. We want our bodies to fight. But if the plaque is not removed and it remains, well, the body continues to fight it, and the very same immune chemicals that were meant to fight the bacteria will unintentionally destroy nearby bone and PDL fibers. This is known as the periodontitis theory. In terms of immunology, what I want you to know is that the most important immune cells here are plasma cells. These plasma cells are what set the stage for the overreaction I was just talking about in periodontitis theory. So plasma cells come from B lymphocytes and they make antibodies to fight the bacteria. But their constant activity causes ongoing inflammation, which ends up damaging other tissues as well. We also run into a process called epithelial shedding. This is where the top layer of cells in the gingiva naturally slough off and are replaced by new cells. So this process tries to help protect the gums by removing bacteria that are attached to the surface and stopping them from going deeper and infecting the tissue. With all of that said, it would make sense that any treatment efforts for periodontitis would focus on modulating or halting the host's immune response, in addition, of course, to removing the plaque. You'll also want to know the bacteria associated with chronic periodontitis, which is known as the red complex. But before we hone in on that one, I want to quickly touch on these different microbial complexes. The blue and yellow complexes are healthy. These are what are considered early colonizers, and they're linked to healthy gums. The next one to focus on is the orange complex. This is the transitionary complex, meaning these bacteria appear as the biofilm matures and becomes more harmful. The important ones that you should know are Prevotella intermedia and Fusobacterium nucleatum. P. intermedia is easy to remember. Intermedia, it's intermediate. And actually, if you were paying attention earlier, you'll recognize these two because they are the same culprits associated with acute necrotizing ulcerative gingivitis. And that makes sense because in ANUG, we haven't had time for the biofilm to mature past these bacteria here. So that's why we see some overlap. Once the biofilm does mature though, we're in chronic periodontitis territory, and that's dominated by the red complex. They include Porphyromonas gingivalis, Tannerella forsythia, and Treponema denticola. These three you definitely need to commit to memory. And to help myself remember the red complex, I use the mnemonic: plaque grows, tissues die, teeth fail. Plaque grows for P. gingivalis, tissues die for Treponema denticola, and teeth fail for Tannerella forsythia. Okay, now we'll talk about plaque formation, which is a stepwise process in which bacteria colonize the tooth surface, organize into complex communities, and mature into a structured biofilm. It begins with the attachment of microbes to the acquired pellicle, followed by the spread of bacteria to new sites in the mouth. So let's start with stage 1. During the initial attachment, early colonizers, mainly gram-positive cocci, adhere to the acquired pellicle. This is followed by permanent attachment, where the bacteria multiply and form colonies that develop into a complex biofilm. In part 1 of the maturation phase, the bacteria secrete extracellular polymeric substance, creating a sticky biofilm matrix that provides protection against antimicrobial agents and host immune defenses. This is the same EPS I was talking about earlier in the video. Moving on, during part 2 of the maturation phase, the biofilm continues to grow and thickens, developing complex microbial communities and nutrient channels that result in a highly structured plaque mass. Finally, in the detachment phase, some bacteria disperse from the mature biofilm, spreading to new surfaces in the mouth and continuing the ongoing cycle of plaque development. Now, one thing that wasn't accounted for in the stages of plaque formation, but is crucial in the development and progression of periodontal disease, are all of the byproducts of these bacteria. The first one we'll talk about are endotoxins, which are primarily derived from gram-negative bacteria. These stimulate an intense inflammatory response, promote bone resorption by activating osteoclasts, and they inhibit fibroblast function, impairing tissue repair. Next, we have exotoxins, which are secreted by both gram-positive and gram-negative bacteria during active growth. They're highly toxic and they can cause significant local or systemic tissue damage. We also have collagenases, which break down collagen fibers within the gingiva and the PDL, enabling infections to spread deeper into the periodontal tissues. Proteases are similar, but they degrade proteins, thereby compromising the protective barrier against bacterial invasion. Lastly, we have hyaluronidase, often referred to as the spreading factor. This enzyme will break down hyaluronic acid in the extracellular matrix, which increases tissue permeability and allows bacteria and their toxins to penetrate more easily through the gingiva and connective tissue. Okay, now there's a specific type of periodontitis characterized by rapid attachment loss and bone destruction. When aggressive periodontitis affects the first molars and incisors, it's known as molar incisor pattern periodontitis. And as the name suggests, the molars and incisors are the teeth that'll be affected, and it's a disease that usually shows up only in teens and young adults. And the key fact that you need to know here is that aggressive periodontitis is strongly linked to a specific type of bacteria, and that's called, get ready for it, Aggregatorbacter actinomycetum comitans. Yeah, that's a fun one to say. It's also just abbreviated as AA, and AA plays a big role in causing the damage in aggressive periodontitis. Okay, so I know I just went over a ton of information, and I want to make sure we understand it all, so I want to do a quick comparison between our healthy state and periodontitis. In a healthy state, the biofilm is primarily composed of non-motile, gram-positive, aerobic, cocci that coexist in balance with the host. Cocci, which here just means they're mainly round-shaped bacteria. Now, as the disease progresses to periodontitis, the environment becomes more conducive to pathogenic species, leading to a shift toward motile, gram-negative, anaerobic bacteria, including bacilli and spirochetes. These changes reflect a transition to a more destructive microbial community that contributes to inflammation, tissue breakdown, and the progression of periodontal disease. Shifting gears here, let's look at Peri-Implantitis, and this is when an implant shows progressive clinical attachment loss. Both Peri-Implantitis and periodontitis share many of the same harmful bacteria. That's the main point here. We have the initial insult by plaque that accumulates around the implant, that causes inflammation, and eventual bone loss around the threads of the implant. Now, there are some bacteria that are unique to Peri-Implantitis, so the two are not identical, but you're unlikely to encounter questions about them, so just know that the composition is very similar to periodontitis as far as the bacteria are concerned. The last thing I want to talk about is stannous fluoride, or SNF2. This is an important ingredient to know for its anti-plaque forming properties, and thankfully, it's in many different types of toothpaste. Stannous fluoride helps fight plaque, which in turn helps fight gingivitis. It also helps prevent caries because it has fluoride. Another source of fluoride in oral care products is sodium fluoride. These are good for caries prevention, but they don't fight gingivitis. So the key point is stannous fluoride helps with both caries and gingivitis prevention. And with that, guys, we are done. I know that was a lot to cover, so let's reinforce everything we just learned with some practice problems. Which immune cells are commonly associated with early gingivitis and chronic periodontitis, respectively? Pause the video if you need some time, but the answer is B. PMNs, specifically neutrophils, are the dominant immune cells in early gingivitis. They're part of the innate immune system and act as the first line of defense against the initial buildup of plaque. In contrast, plasma cells dominate in periodontitis. Okay, next question. Which type of bacteria is commonly present in a periodontal pocket of a tooth with periodontitis? Again, pause the video if you need, but the answer is C, anaerobic gram-negative bacteria. Examples here would be anything in the red complex, P. gingivalis, T. forsythia, or T. denticola. These are all anaerobic gram-negative bacteria. All right, so here's a clinical scenario of a female patient who is 20 years old. Her chief complaint is that her front and back teeth are really loose. She has some family history of early tooth loss, and our current findings include localized probing depths of 6 to 8 millimeters in the first molars and mandibular central incisors. There's also radiographic vertical bone loss in the respective regions. So, the question is, what bacteria is most likely responsible for this disease? Again, pause the video, take some time if you need, but the answer is D, AA. The patient's clinical signs, namely deep pockets and vertical bone loss on molars and incisors at age 20, are all key characteristics of molar incisor pattern periodontitis. Option D, AA, is the key pathogen in molar incisor pattern, and that's what you need to know. All right, last question. Each of the following is a way in which biofilms create protective environments except one. Which one is the exception? Pause the video, read through the answer choices, and when you're ready, hit resume. But the answer is high pathogenicity. This is not a protective mechanism of biofilms. It actually refers to the ability of microorganisms to cause disease, not necessarily its ability to survive in a protective environment. And all of the other option choices here are ones that we discussed at length earlier in the video. So if you struggled on this question, make sure to go back and review the concepts. And with that, we are done, guys. I know that was a lot of information. So as always, here's a quick list of key points we discussed. Thanks for watching, and see you next time.